Welcome to the Melanoma Research Foundation's Ask the Expert webinar series. My name is Miriam Kadosh, and I'm the Director of Education and Patient Engagement here at the Melanoma Research Foundation. We are pleased to have you join us tonight for this wonderful educational opportunity during Melanoma Awareness Month entitled Understanding Melanoma, Risk Factors, Screening Data, and Sun Safety Best Practices. Today, we are joined by a panel of experts who will discuss melanoma risk factors, the importance of early detection through screening, and essential sun safety practices to protect your skin, especially during this Melanoma Awareness Month. First, I'd like to thank our sponsor, EltaMD. We are grateful to them for their generous support of this webinar and investment in the MRF's mission in helping to educate and provide support to the patient community and community at large. We are fortunate this evening to have an EltaMD representative with us today to share more about why EltaMD has made it their mission to engage with the melanoma patient community. We are joined by Michelle McAmey. With over 2 decades of experience as a licensed esthetician, Michelle McAmey has established herself as an expert in advanced skincare education, techniques, and consulting. Recognized by Forbes 5-Star Magazine in 2010 for her expertise, Michelle has made significant contributions to various skincare industries. Beyond her consulting and education roles, Michelle has extensive experience in the treatment room. She has practiced her craft at many top med spas, the Forbes 5-Star Spa at the Four Seasons Resort Vail, Miraval, Austin, and other prestigious skincare clinics. Her skill set extends beyond skincare, as she is also a licensed hairstylist and an award-winning professional makeup artist, having lent her talents to celebrities, television, and magazine publications. In 2022, Michelle brought her expertise to CP Skin Health Group, EltaMD, and PCA Skin, starting as a regional educator. Her skills and dedication quickly led to her promotion to Education Manager of Academia. In this role, she leads educational programs for dermatology residencies at several esteemed universities and aesthetic schools nationwide. You might also catch her on some social media platforms, sharing her knowledge and passion for skincare. Michelle's contributions were recognized in January 2024 when she was awarded Educator of the Year. Michelle, thank you for being here. I'm going to turn it over to you if you'd like to say a few words.
Yes, thank you so much for having me. I'm very proud to represent EltaMD. We are a brand dedicated to enabling everyone to live freely under the sun. And so for the past few years, our support and partnership with the Melanoma Research Foundation's prevention and awareness campaigns and other skin health education initiatives, including free patient and caregiver meetings and educational resources, is really at the foundation of our brand awareness as well. Our mission goes far beyond EltaMD amazing sun care products. We're very passionate about empowering communities of all backgrounds and supporting providers that truly do save lives every day. As the #1 dermatologist recommended sunscreen brand, it is really important that everyone is wearing their sunscreen on a daily basis when it is recommended by a dermatologist. We do know that if you do use daily sunscreen as it's recommended, you can actually reduce the risk of developing melanoma by 50%. So let's all champion together with our sun safety for our friends and family and those in our communities. And it's a pleasure to be here as the EltaMD support, and I look forward to listening in.
Thanks, Michelle. Absolutely. Thank you for being here. Let's talk a little bit about the Melanoma Research Foundation before we get started. And so the Melanoma Research Foundation is the largest independent organization devoted to melanoma. And our mission is to eradicate melanoma by accelerating medical research while advocating and educating the melanoma community, which is what we're doing this evening. The MRF is committed to the support of medical research to develop effective treatments and eventually find a cure for melanoma. And we know that education is critical to patients to make informed decisions about their care. So we have many educational programs and offerings, and they're not only directed at patients, but we create education materials and events for caregivers, family members, and providers that I will speak a little bit more about in a moment. So here are a few of our education literature options that are all free to download on our website at melanoma.org. You can download or order these for print for free. You can order them to your health fair, to schools, to conferences, and we also send these to physician offices and dermatologist offices all over the US. We have 6 animated patient videos and 2 more currently in production. These videos are all less than 10 minutes long and pack a lot of information with great visual images too. So if you have a family member or a friend that want to learn more about melanoma and the process, these are great educational options to send to them and to watch yourself. Each year, the MRF hosts a series of in-person educational events in partnership with major academic medical centers. These meetings provide an opportunity to learn from leaders in melanoma and network with other patients and caregivers. And we actually just completed 4 patient symposia over the past month. You can go back and watch them on our YouTube page. And then we have 2 more coming up in the fall. So please do look out for those dates and locations. All of our past videos are available on our education page on YouTube, on our YouTube channel, as will tonight's recording be there as well in a few days. So if you go on our YouTube site, you can watch any of our past patient and caregiver symposia, webinars like this evening's webinar, and our melanoma educator course. In terms of patient support, we have a variety of patient and caregiver support opportunities and options for you. If there's something you don't see, please let me know and we can find the resource to support you. Online, we have our patient and community forum where you can reach out to other patients. We have a treatment center finder and a clinical trials finder, a financial assistance resources, and an Ask a Nurse hotline. So please do take advantage of these free resources that are available to you. And there are many ways to support our mission and the work that we do through a variety of programs, events, and research funding. We host events such as Patient Symposia and Mile for Melanoma, 5Ks in cities all across the country. And we hope you will join us at one of these amazing events. If you're interested in more information or I didn't answer a question that you may have, please do send us an email at education@melanoma.org. education@melanoma.org, and I'll put it in the chat box for you as well. And learn about the ways that you can engage with the melanoma community while investing in our shared mission together. The best way to learn about the MRF, which is why many of you are here tonight because you heard about this event from our newsletters or from social media. But the best way is to follow us on social media. Here are our social media tags, and it will include information about education, advocacy, our research program, our awareness campaigns, and any upcoming events. So please do follow us on social media, wherever you like to get your media. And lastly, visit us at melanoma.org to learn more. A little bit of housekeeping before we get started. I encourage you to use the Q&A box to ask questions throughout the session. Thanks to everyone who sent in questions ahead of time. We will get to them. But the information presented during today's session is for educational purposes only, and any individual treatment questions that you may have should be directed to your healthcare provider. We encourage everyone to visit us at melanoma.org and know that when tonight's session ends, a survey will pop up on your screen. Please do fill that survey out so that we can be more informed and get feedback about what programs or topics you'd like to hear from us in the future. I appreciate that in advance, so thanks everyone. So now I'm going to introduce our panel for this evening. I'm going to introduce our first speaker. So first, we will hear from Dr. Arlene Ruiz de Luzuriaga, who will share about key melanoma risk factors. Dr. Ruiz de Luzuriaga is an associate professor of medicine in the section of dermatology at the University of Chicago, vice chief for dermatopathology, operations, and co-director of the Pigmented Lesion Clinic. She is interested in epidemiology studies in dermatology and dermopathology, and the use of digital health technology and AI for the improvement of patient care, diagnosis, and treatment algorithms, as well as quality improvement and medical education. Her clinical focus is on total body photography, dermoscopic surveillance, skin cancer surveillance, and melanoma prevention and early detection. She is interested in studying the decision-making experience surrounding ambiguous melanoma neoplasms, how patients and dermatologists incorporate additional data from novel ancillary diagnostic tests for melanocytic lesions, and how the use of digital health applications affect the patient-doctor relationship. Okay, I will turn it over to you. Thank you.
Thanks very much for that gracious introduction. So I'll share my screen now. Just confirming that folks can see my presentation. Miriam.
All good.
Okay, very good. All right, so my first part here, I want to sort of give information but not take up everyone's time because I know we're have a lot of topics to cover, is just looking primarily at the risk factors for melanoma. And then, of course, I'll hand it off to my teammates here to continue to elaborate on that. So I know many of you who are attending this presentation probably understand and know what melanoma is, but just to briefly recap, it is a form of skin cancer, and it develops from the melanocytes, which are the cells that give our skin its color, its pigment. And depending on the tumor characteristics of the melanoma, it can have the ability to spread to other organs. So just by the numbers, approximately 105,000 estimated new cases are anticipated in 2025, with approximately 8,500 deaths. And the incidence rate is 23, and about the mortality rate, or the rate per occurrence, is about 2. And what I would want to say about this is that it seems that the number of melanomas that are being diagnosed is increasing. And granted, if you look at this graph, it's kind of increasing in sort of a very slow rate. And it was 21.9 for 100,000 men and women per year. And again, as we talked about, the death rate was 2 per 100,000 men and women per year. And this is based on data up to 2022 and 2023. The other thing that you'll notice is that the good thing is that overall, the number of deaths is relatively low. And as you can see here in the upper right corner, the estimated 5-year relative survival is 95% approximately. And most of this hinges on early diagnosis, which is going to be reviewed in sort of surveillance and screening and how we find these melanomas. Another thing to note is that among adolescents and young adults, melanoma is also a significant type of cancer that can occur. And in 15 to 19-year-olds, it's not amongst the most common, but in 30 to 39-year-olds, melanoma is included as one of the more common cancer types. So this might be an indicator based on your risk factors, whether or not you should start seeking screening. So what can increase the risk for melanoma? There's a number of factors, and I'll try to cover these in sort of general categories. The most common one that we hear about is ultraviolet light exposure. So this is, an example of a very sunny, bright day where, you could definitely get a lot of ultraviolet exposures. And so that is one of the main known risk factors for melanoma. Now, we think about ultraviolet exposure on very sunny days, but we also have to factor in other aspects of sun exposure. So keep in mind that over 90% of ultraviolet light can penetrate light cloud cover. So even if it's slightly cloudy, you're still getting some UV exposure. In addition, just because it's wintertime or cold and there's snow, that doesn't imply that you're not getting UV exposure at that point. So clean snow reflects about 80% of sun-burning UV rays. Approximately 60% of ultraviolet is received between 10 a.m. and 2 p.m. daily, which is a lot of the reason why we counsel patients to do their outdoor activities earlier in the morning or later in the day. As you go up higher in altitude, UV exposure increases by about 4%. So that's something to keep in mind as well. Indoor workers, so depending on what you do, receive about 10 to 20% of the amount of UV exposure that outdoor workers get on average throughout the year. So most of the time that makes sense that if someone's outside, mostly for their work, they'll get more exposure. Shade can reduce UV exposure by about 50% or more. And keeping in mind when you're swimming or part of your body is submerged underwater, the UV exposure is still about 40% as intense as the surface, even though that part of your body is under the water. Also keep in mind that on white sand, so even if you have an umbrella on, there is some reflection of the UV light off of the sand. And all this is to say is that I always feel for my patients, I don't want them to live in a cave. I want them to enjoy life. And I think part of what's going to be talked about later on in this talk is how to do that safely to sort of be able to be outdoors and enjoy while still reducing those risk factors for excessive UV exposure. So as I mentioned, the time of day, the protective clothing, avoiding tanning beds, so not getting this unnecessary UV exposure, and then sunscreen, which is going to be discussed later on in the talk. So again, the UV light exposure, especially a history of excessive sun exposure or indoor tanning, can significantly increase your risk for melanoma, and also living in an area with increased sun exposure. So the incidence rates of melanoma can vary geographically, primarily due to differences in ultraviolet exposure. So regions closer to the equator at higher altitudes tend to have higher melanoma rates. What else can increase our risk of melanoma besides UV exposure, excessive sun exposure, and living in an area where you get more sun exposure? Well, immunosuppression can. And this doesn't really touch everybody's lives, but it may touch someone's lives that you know. So the main patients or folks that have immunosuppression are those who have undergone a transplant. So a lot of times they're on medications that suppress the immune system so that their organs do not get rejected. But because of this, some of the role of the immune system is to watch out for melanoma and abnormal changes. And so these patients in particular are at risk for melanoma. Also, as you can imagine, in other situations like HIV, where the immune system is decreased, that may also be a risk factor. Another set of important risk factors are family history and also personal history of melanoma. So having a family history or a personal previous history of melanoma or other skin cancers can increase your risk for melanoma, as well as histories of other cancers such as breast or thyroid cancer. So that kind of brings us into the discussion of genetics. So there are some tumor melanoma syndromes that are related to genetics. And these genes that I've put here, which is a lot of alphabet soup, is among the most common genes that can be related to development of melanoma. Because there are several factors that can contribute to the development of melanoma, it's hard to say how much of it is really all related to syndromes. It does seem that the carriers of this particular mutation, this CDKN2A mutation, develop cutaneous melanoma, that's what the CM stands for on this slide, at an earlier age and more often reported a family history of cutaneous melanoma. So these mutations can increase the risk for both melanoma and pancreatic cancer. It's thought that by age 80, patients with this mutation have an increased risk of developing melanoma, in particular in Europe by 58%, in the US by 76%, and in Australia by 91%. And then it's not a foregone conclusion that just because this mutation has happened that you will eventually develop a melanoma, but there are sort of other factors variables that factor in, just as we talked about, like where you live and other risk factors that you're exposed to. It's hard to say with this particular mutation whether or not there's an impact on having a very thin melanoma or superficial melanoma called an in situ melanoma, or the one that's more chronically related to the sun called lentigo malignis subtype of in situ melanoma, which tends to happen a lot on the face in chronically sun exposed areas. In terms of what the recommendation of testing is, it appears that if there is no additional family history of melanoma, if the patient has early onset of melanoma alone, that doesn't necessarily mean that they probably have this mutation. It seems that even in patients who are diagnosed with their first melanoma when they're younger than 40 years old, that less than 1% of them have this mutation. So there's really a lot of other variables at play here. It does seem that this likelihood that one would have this mutation increases with the risk of number of melanomas in the family. So that's another family aspect of history that we usually ask a patient and may determine how often and when we would want to have them start getting screened. It looks like the average age of when melanoma is diagnosed in a patient who has this mutation is usually in their 30s to 40s, whereas if they don't have the mutation, it's usually about a decade or so later. So the recommendation tends to be that if you live in a low melanoma incidence area or population, if you've had two primary melanomas, so two separate ones for yourself, or you have a family with at least one invasive melanoma and another an additional diagnosis melanoma or pancreatic cancer amongst the first and secondary relatives, genetic testing should be considered. In moderate to high melanoma incidence population, they say, 3 melanomas because there would be just naturally a higher number of melanomas. And then also the requirement for families also increases to 2 or more melanomas. So it takes into account both your family history and also where you live. So we sort of went over this. Generally speaking, if you've had 3 or more melanomas that are sort of thicker and diagnosed before your 45th birthday, or 3 or more blood relatives on one side of your family who've had melanoma, or this other type of mole called a Spitz nevus, if you have 2 or more, or 1 or more Spitz moles that also had one of these other types of tumors, genetic testing may be recommended. At our institution, we do sort of individualize it, and we have genetic counseling teams that sort of walk a patient through what makes sense to test and why. Lastly, I'm just going to go quickly over moles. So moles, just having a few moles does not necessarily increase your risk for melanoma outright. Usually having more than 50 or having large or unusual atypical moles are really kind of a more important risk factor for developing melanoma. As many of you probably know, the majority of melanomas arise not from a mole that you've had since you were a kid. A lot of times when it comes, it was a melanoma to begin with and is not coming from a pre-existing mole. So that is something important to keep in mind. I know later on we'll talk about, how often we should expect to get moles, et cetera. So we'll go over that. But keeping in mind that the main risk factor is having a lot of moles. So whether within melanoma-prone families, whether they have this mutation or not, having a lot of these clinically atypical moles and also dysplastic nevi is a strong risk factor for melanoma development. So I will pause there and I will turn it over to my colleagues.
Great, thank you so much. I learned a lot there as well, so thank you. And we're going to save questions for the end, so please hold your questions for our question and answer panel at the end. So next, I'm going to turn it over to our next speaker, Dr. Hilary Tsibris, who will speak about the critical role of early detection and screening. Dr. Hilary Tsibris is an assistant professor of dermatology at Harvard Medical School and an associate physician in the Center for Melanoma Oncology at Dana-Farber Cancer Center. She completed her medical degree at Harvard Medical School, including a 1-year dermoepidemiology research fellowship, and graduated cum laude with honors in research. She completed her internal medicine internship at Brigham and Women's Hospital and her dermatology residency at the Harvard Combined Dermatology Residency Program, where she served as chief resident her final year. She joined the Center for Melanoma Oncology at Dana-Farber Brigham Cancer Center in 2016, where she currently serves as the medical director for Dermatologic Oncology and has pioneered the use of novel treatment options and surveillance strategies. She divides her time between patient care and research, focusing on melanoma genomics and innovative strategies for early detection of melanoma recurrence. Turn it over to you, Dr. Tsibris.
Thank you so much. I really appreciate that kind introduction. Thank you
Mhm.
to everyone for joining us tonight and to the Melanoma Research Foundation, both for the crucial role that you play in funding research that extends patient lives and for this educational opportunity tonight. So, as Miriam mentioned, I'm going to be talking about the critical role of early melanoma detection and screening. So, as we just heard, melanoma is the fifth most common cancer in men and women in both the US and Europe. And many of my patients ask whether melanoma is more common than it used to be. And as we just discussed, the answer to that is yes. The incidence of melanoma right now is 6 times higher than it was 40 years ago. And you can see in the graph that I'm showing here, it shows the incidence of invasive melanoma, which is the dark blue line, and in situ melanoma, that's early melanoma restricted to the top layer of the skin from 1975 to 2015. Lots of folks wonder why we're seeing an increase in melanoma rates. And there are probably a number of factors that are contributing. So there certainly have been lifestyle changes. So people are getting greater sun exposure from sunbathing, and we saw the introduction of indoor tanning during this time period as well. We have an aging population, and we know that melanoma is more common in adults who are over the age of 50. There's also the possibility that we're doing increased screening. So we're detecting more melanomas. And this very dramatic rise in situ melanomas may be partially because pathologists are more cautious than they were in the past. And maybe some of these atypical moles are now more likely to be diagnosed as in situ melanoma. What is really interesting, and what was just touched on in the prior talk, is that while the incidence has gone up, and again, this is the graph on the left-hand side that shows the incidence of melanoma from 1975 to 2015, mortality stayed flat and then began to go down in 2015. And actually, melanoma death rates have shown the steepest decline of any cancer type in the US, starting around 2015. And that decline, as you can see, on the left is men, on the right is women, is 4 to 5% per year. And this is likely due to therapeutic advances that have been critical for the treatment of metastatic melanoma. We've seen the introduction of targeted therapies that block specific mutations that are commonly seen in cutaneous melanoma. And we've seen the introduction of immunotherapy. These are the immune checkpoint inhibitors that activate our own immune systems, our own cancer-fighting cells that allow our immune cells to destroy melanoma. Okay, so we have therapies that are improving outcomes once the melanoma has spread, but how do we prevent it from spreading in the first place? There's a very clear answer. We catch it early. As a dermatologist, this is where I think our role is so important. So we know that early diagnosis improves outcomes and improves survival. So this is a graph here that shows melanoma survival by tumor stage. What you're seeing, so the top 2 lines, the red and the green, are our thinnest melanomas. These are the ones that are less than 1 millimeter. The thinner the melanoma, the lower the risk it spread. Our next thickest melanomas are the orange and the blue lines, followed by the brown and the red, and so forth. And what you can see is that as our tumors get thicker, our melanoma survival declines. So for our thinnest melanoma, the 10-year survival is 98%. When you get down into our thicker melanomas, we're getting closer to 75 to 83%. And these are all tumors that are limited to the skin. They haven't yet spread to lymph nodes or other places distantly in the body. So based on this data, it's clear that our goal should be to catch tumors as early as possible to improve survival. However, there is some controversy about the best and the most cost-effective way of doing so. So believe it or not, there is this question out there of whether we should be screening. And actually, routine screening for early detection of skin cancer is not currently recommended by the U.S. Preventive Services Task Force. And that very much differs from other countries. If you look in Europe, Germany, Austria, and France all have guidelines that recommend screening. And there is data that supports that total body skin examinations are effective at catching early melanoma. So we're going to look at what I think is one of the clearest studies that shows that. So this is a study that was conducted in Germany in 2003, and it was huge. They included 360,000 citizens who all received a standardized whole body skin examination between 2003 and 2004. So this graph on the left-hand side shows the number of melanomas that were diagnosed, that is the incidence of melanoma, before the screening took place. And this black box that says Screen Project is when they did the whole body screening. During that time period, they detected 3,100 melanomas, which was a 34% increase in the diagnosis rate of invasive melanoma. So the next question is, did that help? And the answer is yes. So this graph that we're looking at on the right shows melanoma mortality. So the black box again is when they did the screening, and you can see that 5 years later, they saw a substantial decrease in melanoma mortality. So this is pretty clear data that screening detects more melanomas and then improves mortality down the road. There's a separate question of whether screening is cost effective. When researchers try to answer this question, they look at the cost per life year saved for any treatment or intervention to decide whether they think it's cost effective. In the US, and this has clearly fluctuated over time, but the CDC has previously used about $50,000 per life year saved as a reasonable threshold to consider an intervention. So there was a study that looked at the cost per life year saved for dermatologic screening for high-risk individuals in the US. And this was a one-time screening by a dermatologist. High-risk individuals in this study included people who were fair-skinned, who burn easily and tan poorly, or people who have a family history of skin cancer, extensive sun exposure, or a higher than average number of moles, right? All those risk factors that we just touched on in the last talk. And what they found was that this one-time screening by dermatologists cost $29,000 per life year saved. So certainly below that $50,000 threshold I just talked about. And this table at the bottom compares it to other standardized screening programs that we do. So in comparison, PSA annual screening costs $152,000 per life year saved. A pap smear every 3 years is $46,000. An annual mammogram between the ages of 55 and 65 is $32,000. So, less than all of those interventions as well. There was another study that came out of Australia that estimated a lower cost, $12,000 per life year saved for men and $21,000 for women for screening done every other year in a primary care setting for people over the age of 50. So I would say that this data argues that screening is also cost effective. So if we're not going to screen everyone, because these studies are looking at higher risk populations, who should we be screening? This was a study done in 2018 that attempted to identify groups that are higher risk for melanoma whom we should focus our screening on. And so they tried to identify groups where screening the fewest individuals and performing the least number of biopsies could diagnose a melanoma. So if you looked at everybody together, they had to screen 215 people on average to diagnose one melanoma. And they had to biopsy 28 lesions to diagnose one melanoma. But there were certain groups where those numbers were much lower. We had to screen fewer people and do fewer biopsies to identify melanomas. So those groups are people who are over the age of 51, male in general. Fewer people needed to be screened amongst men to diagnose a melanoma, and people who had a personal history of melanoma. So maybe these are groups that we should be focusing some of our screening effort on. Other factors we could consider for targeting screening, skin pigmentation. So we see a 2 to 4-fold increase in melanoma risk with light skin, blue eyes, red hair, and a high freckle density. So people who have that group of risk factors maybe are people who should receive greater attention. People who have a high number of moles, so 50 to 100 moles, have a 7-fold higher risk than those who have just 0 to 4 moles on their body. People who have atypical moles or atypical nevi, those are benign moles that share some of the clinical features of melanoma, some of the atypical features we might worry about. Those folks have a 1.5-fold higher risk if they have one atypical mole, and a greater than 6-fold risk if they have 5 or more atypical moles. And then certainly people who have a family history and the genetic syndromes that were just discussed in the last talk. So what can we do for screening? Certainly in-office examinations are part of that, critically important, particularly for areas where people can't see on their own body. Self-skin checks at home also have a critical role. I'm always explaining to my melanoma patients that I want them checking their own skin every month or two. And you all are here, so my guess is you've heard about the ABCDs before, spots that are asymmetric, so different side to side, that have irregular edges or borders, multiple colors, black and pink mixed together, a diameter that's more than 6 millimeters, or a spot that's evolving and changing, right? Growing in size, changing in shape. I always add ugly duckling. So that's just a spot that looks different than all the others on the body. And pink spots that are new and that don't go away after 2 to 3 weeks, because we certainly can see amelanotic melanomas as well. And so these are things that people can look for on their own skin. There also are a lot of new approaches to diagnosis and screening out there. There's confocal microscopy. That's a low-power laser beam that magnifies cells in living skin. This has a 92% sensitivity for melanoma detection, and some studies have found a 43% reduction in biopsies compared with standard practice. There's total body photography that we can talk about a little bit more in the question and answer session. These are software-based programs that use AI to compare images from different time points. And studies have shown these reduce the number of biopsies performed and might also decrease the thickness that melanomas are diagnosed at. And then there are these elastic scattering spectroscopy devices that have been introduced for non-dermatologist physicians that have noted that light is scattered differently by benign and cancerous lesions. They're pretty good at identifying when something is benign, but if they say that you need to investigate it further, it's not necessarily a cancer. Okay, so what can we do? Remember, this is a partnership, and I tell all of my patients that you can make sure that you know what you're looking for and keep an eye on your own skin and those of your loved ones. If you're in a high-risk group, you can get checked. You're here, so I'm sure that folks are on top of that, and you can encourage others to get checked as well. For those of us who are speaking here today, it's certainly our goal to do screening to identify melanoma early, to use and develop new detection technologies and screening guidelines, and to do education. So programs like this that help to inform the community. With that, I would thank you guys for your attention. This is a photo of my kids on the beach a couple of years ago, trying to do their best to protect themselves. And I know this is very different than how we looked at the beach, a generation or two ago. But this is the type of sun protection we're encouraging. And at the very least, you're going to know whose kids on the beach have dermatologists as parents. So I'd like to thank the MRF and Dana-Farber, where we spend a lot of time thinking about cancer and melanoma. And with that, I'll thank you for your attention.
Thank you so much, Dr. Tsibris, for sharing the important message about screening this Melanoma Awareness Month and all year long. We're going to turn to our final panelist here. We will hear from Dr. Correa-Selm, who will share about essential sun safety practices to help prevent melanoma. So Dr. Correa-Selm is a U.S. board-certified dermatologist and internist, international dermatologist, fellowship-trained Mohs micrographic surgeon, and expert confocalist. She is currently an associate professor of dermatology and dermatologic surgery at the University of Florida and Moffitt Cancer Center, and is the vice chair of TGH Dermatology Institute. Prior to being at USF and Moffitt, she was the director of cutaneous surgery at Cleveland Clinic Indian River Hospital, while also teaching as an assistant professor at FSU. Before moving to Florida, she completed a fellowship in Mohs micrographic surgery in New Jersey after completing her dermatology residency at Rutgers Robert Wood Johnson Medical School. Additionally, she is also accomplished in confocal microscopy fellowship and a laser cosmetic research fellowship. She also performed research at Memorial Sloan Kettering Cancer Center in New York, completing her internal medicine residency at Cornell, New York Downtown Hospital, and performed research at Harvard's renowned Beth Israel Deaconess Medical Center in Boston, following spending 1 year as a physician in a remote, underserved area of South America. She is a published author of numerous book chapters in dermatology, as well as articles in important medical journals. Thank you, Dr. Correa-Selm, for being here this evening.
Thank you, Marian, and thank you to the Melanoma Research Foundation for this kind invitation. I think this is a great opportunity for all the melanoma patients to learn a little bit more about this important disease. So I'm gonna share my screen. Okay, perfect. So I'm gonna talk a little bit about how can you be safe under the sun. Like Michelle said before, is you can have fun and you can go outside as long as you protect yourself. A lot of my patients usually tell me after I do a skin cancer surgery, they're like, well, Dr. Correa, now I can't go to the sun, like, or when can I go back to the sun? I said, listen, you always can enjoy the sun as long as you do it smartly and you do what you're supposed to do. So a couple of recommendations that I always say. So first of all, this is not necessarily under the sun, and I believe Dr. Ruiz mentioned this too. I cannot stress enough the avoid use of tanning beds. Unfortunately, I thought that at this day and age, this was something that people doesn't do anymore, but it happens to be that they're still very in use. More or less, the teenagers still say hair, nails, and tanning beds, which it's a huge mistake. They shouldn't be used, not even once in a lifetime. They increase the risk of melanoma only with one use. So we should be very aware of this and try to spread out these important recommendation. The other thing that I usually say is try to be mindful when you're outside and try to seek shade whenever possible. So if you're in a soccer game, if you're in a tennis game, if you're in a concert, and you have the opportunity of seek shade, always do. Even if you're wearing a hat, even if you're wearing long sleeve, because the least you're exposed, the better. The other thing I usually say is wear wide brim hat. So it's very common that I have a lot of male patients in my practice with skin cancers in the top of the ear, because unfortunately majority of them wear short hair, and it doesn't protect the top of the ears or even the back of the neck. That's a very common area where I practice surgery for skin cancer, because same token, the hair doesn't protect that area. So they have to be mindful of wearing a hat where it protects the ears and the back of the neck. there alternative to this, because I also have, since I live in Florida and I practice in Florida, my male patients also say, well, Dr. Correa, that's kind of ridiculous. I'm not going to wear a wide brim hat. Those are for women, right? So I tell them, well, then you can just buy a fisherman hat, right? Which are the ones that have like little flops, which they're not wide brim, but they have the flop that wraps around and actually protects the ears and the posterior neck. The other important thing that I usually say, try to be mindful with your hands, because that's another area that it gets very commonly forgotten. And like I said, I also do a lot of skin cancer surgery on them. So, for example, patients that are gardeners, they tend to forget to protect their hands. So I tell them, try to wear gloves when you're going to be outside working on your garden, because as you know, sometimes the shirts just go onto the wrist and they don't protect the hands. Now, there are some SPF clothing that actually have protection up until the fingers, so you can just put your thumb through them and they protect the whole hand, but not all of them do. So just be very mindful of that part. Then, of course, use some protective clothing. I think we have already talked about that. There are a few characteristics that I recommend the patients to look for it. So some of them have a certified UPF, which is more or less the SPF, but in clothing. So if they are certified, they're supposed to be to give you enough protection to be outside. But another thing you can do, if you put them through the sun, and they don't reflect any light, they should be good. And then also importantly, darker colors are better, even though you're gonna feel a little bit more warm. But obviously, when you wear brighter colors, they are less likely to protect you. Then apply sunscreen of at least SPF 30. So I usually say at least, because I mean, it's been described that 50 is more for like when you're at low UV index between 0 and 2. When you go above 3, it's usually recommended to do at least SPF 30. And then reapply every 2 hours or after profusely swimming or profusely sweating or swimming. So this is very important, because obviously after any of those activities, the sunblock is gonna wear off. So we have to be mindful on reapplying if we're not sufficiently protected. And then the last thing, more importantly for patients that have had melanomas, is perform monthly self-skin exam with special attention to mouth, genitalia, hands, and feet. This is something I usually tell my patients that I just diagnosed with melanoma, because they're very, very anxious, and they're like, wow, now how am I gonna know? And they come to their next full skin exam asking me about like 30 spots, because obviously they feel so overwhelmed with so many spots. So I tell them, listen, your first 2, 3, 4 exams are going to be very overwhelming, because you're not familiarized yet with what you have. But once you reach the 4th and the 5th, you're like, oh yeah, I know this spot. Oh yeah, this spot I have before. So I tell them, just try to calm yourself down. It's okay, bring it to me. I'll be happy to check it, but don't get very overwhelmed, and don't try to check yourself every day or every week. So the best thing is just forget about it, pick a day of the month, and that's the day when you're going to dedicate yourself to just kind of like look at yourself very, very attentively. So, and other than that, unless it's something very obvious, don't get very nervous about it. Then I want to go a little bit over sunblocks, because I think this is a very important topic that, thanks to all the social media, is kind of up there. Every few months, we receive an article in the Wall Street Journal or any, like a New York Times about sunblocks. And then, every time, like 1 out of 3 patients every day, they ask me about sunblock. So I kind of want to give a little bit of a talk about this. So more importantly, there are 2 types of sunblocks. There are the chemical filters and the physical filters. So the chemical filters work mostly on the skin, and they dissolve the UV rays into heat. They more or less disperse that UV ray into heat. Physical filters are more like a block, so more or less they are a screen that just reflect the UV ray. So based on this, usually we dermatologists said that physical filters are a little bit safer and a little bit better in terms of protection. We usually try to favor those. And a few years ago, there was also this controversy about chemical filters damaging the coral. So those are the ones that are not allowed, for example, in places like Hawaii, versus physical filters where they can be used because technically they're not damaging to the sea, the coral. So usually we tend to prefer physical filters. So here on the right side, you have the two type of physical blockers, which are only two ingredients. One of them is zinc oxide, and the other one is titanium dioxide. Then we have a lot more chemical filters, which you can see them here. One of the ones that were most culprit for damaging was the oxybenzone. That was the one that was all over the place. Unfortunately, we don't have as many here as there are in Europe. In Europe, they have much more that tend to be a little bit safer. Here, these are the only ones allowed as per the FDA. So those in terms of sunblock. Now, there are other substances that have shown to be antioxidant. And what antioxidant means is they are substances that can remove some of the free radicals that has been shown to ultimately cause the damage to the cells and produce that type of actinic damage that can evolve into precancer or cancer. And some of the extracts or elements that have shown to have this type of properties are polyphenolics, which are, for example, the green tea extract is one of them. The other ones are, for example, something called pycnogenol that is in some creams, and also something called polypodium leucotamose, which it's usually an oral pill that has, people call it like an oral sunblock, more or less, because it kind of also helps with free radicals when you take it orally. Then other ones that had been also shown are DNA repair systems, and like most of these are experimental, so they've been shown in bench work that they prevent the production of free radicals, but none of them are really still commercially available, unfortunately. One of them that I wanted to mention is caffeine and sodium benzoate. So that has been shown to be free radical, but I'm not aware of any product that actually uses it. And then oral, I already mentioned the polypodium leucotamose. Some vitamins are also, for example, niacinamide, vitamin B3 has been shown to have antioxidant properties and protective to skin cancer. And then also green tea has been shown orally to prevent it. So I think that's me so far. I'm gonna stop.
Great, thank you. I'm going to ask all of our panelists to come back on the screen so we can do a final Q&A. I have a few questions, but just based on the sunscreen conversation that we were just having, I have a few questions about sunscreen that were sent in from audience members, and anyone can answer this one, but how much sunscreen should you apply each time you apply sunscreen?
I think oftentimes if you're doing the whole body, the standard people say is a shot glass full. And so usually that's the amount you estimate if you're putting sunscreen over your whole body. I would say that, that differs if you're doing the combination of sunscreen and sun protective clothing, which a lot of us advocate for. So if you're wearing a UPF protective sun shirt, perhaps that's slightly decreased.
Do you need to put sunscreen on underneath UPF clothing? Just to add on to that question, Dr. Tsibris?
Not unless you're taking it off.
I've had patients ask me that question as well. And I think the one thing that I always tell them is that the UPF on the UPF substance on the fabric is not indefinite. And they should bear that in mind over time that, there are some, I don't know if they make them anymore, but there used to be a way to wash in the UPF. But just so that they know that if it doesn't seem to be working as well, that's probably a good thing, and they should trust their instinct if it doesn't seem to be protecting them as well as it used to. And maybe either the weave might also be getting a little looser, et cetera. So another factor for them to keep in mind in terms of whether or not they should add some sun protection if it's like an older piece of clothing.
In terms of folks that have already had melanoma, what should they look out for in terms of sunscreen and sun protection?
So I think I mentioned it before. So I think they can be outside because it's typical, my patients get so traumatized that they're like, oh, now I won't be able to go out in the sun ever. I don't think that is true. I think they can enjoy outdoors activity, but they just have to be very mindful on how to protect themselves. As we saw from the talks from Dr. Ruiz, they have increased risk of melanoma versus the normal population. So obviously, if they're out of developed melanoma, the numbers are not in their favor. So they have to be a little bit more careful. But I would say same thing, same recommendations that I gave, SPF at least 30. When you are on a UV index more than 3, reapply every 2 hours if you profusely sweat or if you swim. And then, kind of make sure you wear the sunblock that you like, because that's the one that you're actually going to wear.
That's such a great point. I think people come to us all the time and say, there's so many different options when they are in the aisle at the grocery store, and what's there to go for. And so what you're saying is 30 and up. Any other tips there on things that patients should look out for?
Broad spectrum. So making sure their sunscreen says broad spectrum, so it's also protecting against ultraviolet A, not just UVB.
And one last thing to throw in there, that they sort of changed how they call like waterproof. And so there's water resistant, and they'll put on there how long it's water resistant for. Typically the parameters is 40 minutes, 80 minutes. So patients should keep that in mind when they're out in water activities in terms of how often to reapply and which kind to choose in that context.
Right, so it doesn't mean waterproof. They can put it on in the morning and it's gonna last all day.
Yep.
Okay. So, Dr. Ruiz de Luzuriaga, once you have a melanoma removed, how common is it to have additional moles or growths appear?
So, I think I've thought about this a lot, and a lot of patients ask this because obviously once you've had a melanoma, every new mole that appears is a very frightening experience. And a lot of times, especially if they're young, I sort of have them keep in mind that, you're gonna continue to get new moles for 10, 20 more years probably. And at some point, I say when you're 70, you probably will have much fewer of them. So something to look forward to. But it is, partially genetics. So it's interesting. They looked at this study where there were sets of twins, and it seemed like if the twins were sort of identical twins, they got sort of about the same numbers of moles over time. Whereas if they were fraternal twins, they didn't seem to have that relationship. So there's definitely this environmental aspect to it, but also a very strong genetic aspect to it. So sometimes patients with melanomas, they don't have a lot of moles, and sometimes they do. So I think my short answer is it is fairly common. Not every new mole is going to be alarming. And, sometimes we just take into account where it's located, how quickly it appeared, and what their age group is.
Classic nature versus nurture question, for sure. Okay, we only have a few more moments this evening. So Dr. Tsibris, I'm just going to ask you a question that we've received ahead of time about asking if there's a blood test to detect melanoma early, and anything that you can share about AI in terms of early detection, which you talked a little bit about.
Yeah, I'll try and answer both of those fairly quickly. So the answer is No, there is not specifically a blood test to detect early melanoma, but there is a molecular test that we're using for monitoring advanced melanoma patients. So this is circulating tumor DNA, sometimes called a liquid biopsy. So the idea is that DNA from the melanoma tumor can be released into the bloodstream, and then it can be detected on blood draw. So you cannot use this currently to detect skin-limited melanoma or for early detection of melanoma on the skin instead of standardized screening. But for people who have metastatic disease, this has now become a part of our monitoring for recurrence or for response to treatment. Separately, the question about total body photography and AI, there are a number of different systems that are out there. Photo in the top left is of the Vectra system that in a single capture gets the entire body. Bottom left is the system that we use at Brigham and Women's, which is called Derm Engine, and it's an iPad-based platform. But the idea is that you capture images that make a 3D composite of the body, and then AI software detects changes over time. So for example, in this case, it highlighted that this was a new lesion that had appeared on this gentleman. And as I touched on, there are a number of studies that find that this type of mole mapping reduces the number of biopsies performed and the thickness at which melanomas are diagnosed. We tend to reserve this for our patients with a high density of atypical moles and either a personal or a family history of melanoma.
Thank you very much. All right, everyone. With that, we're going to conclude our Q&A panel. And I would like to thank you all for joining us today. I'd like to thank our sponsor, Elta MD, Michelle, and especially our speakers for presenting today during this Ask the Expert session during Melanoma Awareness Month. We appreciate all that you do for the melanoma community this month and all year round, and appreciate you taking the additional time to be with us this evening. Again, this program will be available on YouTube in just a short few weeks. And at the end of the program, like I mentioned earlier, when you close your screen, there will be a short evaluation that will pop up in your browser. Please fill that out. It does provide us with feedback on today's session and helps us create new programs for the future. Again, visit melanoma.org to learn more about our upcoming webinars and other educational, advocacy, and research opportunities. If you have any questions that you think of later, please feel free to email us at education@melanoma.org. Thank you, everyone. Thanks for joining.